Good morning, dear students. Our lecture today is Functional Anatomy of Respiratory System. Respiratory system comprises the organs responsible for the air passage, respiratory metabolism, voice producing, inhaled air perception, clearing, warming, and humidification. These organs may be divided in the respiratory tracts, upper and lower, and the lungs. The pulmonary alveoles are directly responsible for diffusion of the gases, oxygen and carbon dioxide to blood and back. Respiratory system consists of upper respiratory tract and lower respiratory tract. Upper respiratory tract consists of nose, nasal cavity, paranasal sinus, pharynx, and lower respiratory tract consists of larynx, trachea, bronch, and lungs. Development of the lower respiratory tract. Begins to form during the 4th week of development. Begins as a median outgrowth, laryngotracheal groove. From the caudal part of the ventral wall of the primitive pharynx. The groove invaginates and forms the laryngotracheal diverticulum or respiratory diverticulum. Respiratory diverticulum. A longitudinal tracheoesophageal septum develops and divides the diverticulum into a dorsal portion primordium of the esopharynx and esophagus, ventral portion Primordium of larynx, trachea, bronch, and lungs. Dorsal portion, ventral portion. Dorsal portion, ventral portion. Repeat this information again. Dorsal portion, primordium of the esopharynx and oropharynx. Ventral portion, primordium of larynx, trachea, bronch, and lung. The proximal part of the respiratory diverticulum remains tubular and forms larynx and trachea. The distal end of the diverticulum dilates to form lung bud, which divides to give rise to two lung buds, primary bronchial buds. The endoderm lining the laryngotracheal diverticulum gives rise to the epithelium and glands of the respiratory tract. The surrounding splanchnic mesoderm gives rise to the connective tissue, cartilage, and smooth muscles of the respiratory tract. Development of the larynx. The opening of the laryngotracheal diverticulum into the primitive foregut becomes a laryngeal orifice. The epithelium and glands are derived from endoderm, laryngeal muscles, and the cartilage of the larynx, except epiglottis, develop from the mesoderm of fourth and sixth pairs of pharyngeal arches. Epiglottis. It develops from the caudal parts of the hypopharyngeal eminence, swelling formed by the proliferation of mesoderm in the floor of the pharynx. Hypopharyngeal eminence, laryngeal groove, laryngeal islet. Growth of the larynx and epiglottis is rapid during the first 3 years after birth. By this time, the epiglottis has reached its adult form. Recanalization of larynx. The laryngeal epithelium proliferates rapidly, resulting in temporary occlusion of the laryngeal lumen. Recanalization of larynx normally occurs by the 10th week. Laryngeal ventricles, vocal folds, and vestibular folds are formed during recanalization. Development of the trachea. The endodermal lining of the laryngotracheal tube, distal to the larynx, differentiates into the epithelium and glands of the trachea and pulmonary epithelium. The cartilages, connective tissue, and muscles of the trachea are derived from the mesoderm. Development of the bronchs and lungs. The two primary bronchial buds grow laterally into the pericardio-peritoneal canals, part of the intraembryonic cell. The primordia of pleural cavities. Bronchial buds divide and redivide to give the bronchial tree. On the picture, you can see pericardioperitoneal canal, trachea, bronchial buds. Somatic mesoderm, splanchnic mesoderm. Then visceral pleura, parietal pleura, pleural cavity. The right main bronch is slightly larger than the left one and is oriented more vertically. The embryonic relationship persists in the adult. The main bronch subdivides into secondary and tertiary or segmental bronch, which give rise to quasi-bronchs. The segmental bronchi, 10 in the right lung and 8 or 9 in the left lung, begin to form by the 7th week. The surrounding mesenchyme also divides. Each segmental bronch with its surrounding mass of mesenchyme is a primordial of a bronchopulmonary segment. By 24 weeks, about 17 orders or branches have formed and respiratory bronchioles have developed. An additional 7 orders or airways develop after birth. As the lung develops, they acquire a layer of visceral pleura from splenic mesenchyme. The thoracic body wall becomes lined by a layer of parietal pleura derived from the somatic mesoderm. Splenic mesoderm, somatic mesoderm, bronchial buds, trachea. Then visceral pleura, parietal pleura, and pleural cavity. Maturation of the lungs. Maturation of lungs is divided into 4 periods. Pseudogranular, from 5th to 17 weeks. Canalicular, from 16th to 25th weeks. Terminal sac, from 24th weeks to birth. Alveolar, late fetal period to childhood. These periods overlap each other because the cranial segments of the lungs mature faster than the caudal ones. Pseudogranular period. Developing lung somewhat resembles an exocrine gland during this period. By 17 weeks, all major elements of the lung have formed except those involved with gas exchange alveoli. Respiration is not possible. People born during this period are unable to survive. Canalicular period. Lung tissue becomes highly vascular. Lumen of bronchi and terminal bronchioles become larger. By 24 weeks, each terminal bronchioles has given rise to 2 or more respiratory bronchioles. The respiratory bronchioles divide into 3 to 6 tubular passages called alveolar ducts. Some thin-walled terminal sacs, primordial alveoli, develop at the end of respiratory bronchioles. Respiration is possible at the end of this period. People born at the end of this period may survive if given intensive care, but usually die because of the immaturity of respiratory as well as other systems. Terminal sac period. Many more terminal sacs develop. Their epithelium becomes very thin. Capillaries begin to bulge into developing alveoli. The epithelial cells of the alveoli and the endothelial cells of the capillaries come in intimate contact and establish the blood-air barrier. Adequate gas exchange can occur which allows the prematurely born people to survive. By 24 weeks, The terminal sac are lined by squamous type first pneumocytes and rounded secretory type second pneumocytes that secrete a mixture of phospholipid called surfactant. Alveolar period. At the beginning of the alveolar period, each respiratory bronchiole terminates in a cluster of thin-walled terminate sacculus, separate from one another by loose connective tissue. These terminal sacculus represent future alveolar sacs. The epithelial lining of the terminal sacs impaired to an extremely thin squamous epithelial layer. Characteristic mature alveoli do not form until after birth. 95% of alveoli develop postnatally. About 50 million alveoli, 1/6 of the adult number, are present in the lungs of a full-term newborn baby. Most increase in the size of the lungs results from an increase in the number of respiratory bronchioles and primordial alveoli, rather than from an increase in the size of the alveoli. From 3 to 8 years or so, the number of immature alveoli continues to increase. Unlike mature alveoli, immature alveoli have the potential for forming additional primordial alveoli. By about the 8th year, the adult complement of 300 million alveoli is present. Breathing movements. Care before birth are not continuous and increase as the time of delivery approaches. Help in conditioning the respiratory muscles. Stimulate lung development and are essential for normal lung development. Lungs at birth. The lungs are half filled with fluid, derived from the amniotic fluid and from the lungs and tracheal glands. This fluid in the lungs is cleared at birth by pressure on the fetal thorax during delivery, absorption into the pulmonary capillaries and lymphatics. Lungs of a newborn. Fresh healthy lung always contains some air. Lungs float in water. Diseased lung may contain some fluid and may not float, may sink. Lungs of a stillborn infant are firm, contains fluid, and may sink in. Factors important for normal lung development. Adequate thoracic space for lung growth. Fetal breathing movements. Adequate amniotic fluid volume. Developmental anomalies. Laryngeal atresia. Tracheoesophageal fistula. Tracheal stenosis and atresia. Congenital lung cyst. Agenesis of lungs. Lung dysplasia and accessory lungs. Tracheoesophageal Fistula. An abnormal passage between the trachea and esophagus. Results from incomplete division of the cranial parts of the foreguts into respiratory and esophageal parts. Case runs in 3,000 to 4,500 live births. Most affected babies are males. In more than 85% of cases, the fistula is associated with esophageal atresia. And again, repeat. Is abnormal passage between the trachea and esophagus. So, dear students, our lecture was about very important parts, very important system of the human body, respiratory system. Thank you very much. Thank you for your time. Goodbye.